Hello, everyone, and welcome, Beth. I am so excited to have this conversation with you. I mean, think about where we are now and compared that to when we met. I think, gosh, it was about 8 years ago, and I was at the state of California in the Department of Public Health, just starting this open data initiative. And you actually you had just left the state of Maryland. You were directing state stat for the governor, and you really became one of my key data experts at the time. And so here we are now at what we kind of hope is getting toward a tail end of a global pandemic. And we can recognize that public data, that thing that you and I both love so much, is having this very special moment. What's different now?
Wow. Yeah. Well, it's been a really long 8 years, and most of that length, I think, occurring in the last 12 months. So, we are in such a exceptional moment in time, and particularly for data. And so here we are now with vaccines being, jabbed in arms. And we finally see a little bit of that glimmer at the light of the end of the tunnel. And one of the big headlines from this global experience of COVID that we've had is data, and the moment that data has had, and the role that data has played in not only framing our daily activities and the way that we interact with each other and our families, but also the way that public policymakers have been thinking about their response to COVID and everything related in between. And so, yeah, we are here at a very different place than we have ever been as we think about public data and data as an asset.
Yeah, I mean, I think you guys, and I've spoken about it many times in many different venues at Johns Hopkins, have really created a new standard for open data and sharing, and you've enabled thousands to do more with data around COVID-19.
That's right. So, we're now coming, or just past our 1-year anniversary, where Dr. Gardner, my friend and colleague here at Johns Hopkins University, started tracking the pandemic in our global map. And the map itself has really been a lightning rod for huge dialogue and conversation, not only around COVID, but around the role that data has played. And we've become that standard bearer. In the absence of a global standard, we have had to kind of step up and fill in. And we're seeing it also nationally. In the absence of standards, have really been at the front lines of not only understanding the data, understanding what it means, understanding how it's impacting policy decisions, but also understanding why these standards are so important, and the creation of a common language around this disease in particular, but around public health in general, has never been more urgent. And we're seeing, really the need for that and the urgency in all fronts, in both the public health response, the medical response, and the policy response.
Yeah, no, I think that's really true. I mean, I think what the Hopkins data did was really expose in a very painful way some of that lack of data standardization. And I wonder what you think. I mean, that seems like something that we should be able to get a hold of, right, and do better in terms of data standards. And of course, in this scenario, you and I are having this conversation before a federal government audience. What do you think is the federal government's role in supporting data standards?
Look, I think the CDC, has done as good a job as possible given the kind of framework or the context that they've been working within. And we've seen, actually, even in the last several months, some really great guidance around how data should be collected, how data should be shared. But it's not necessarily the kind of influence that the states really need. At this point, the states and local government really need very clear reporting requirements. You're getting these vaccinations, and in return, this data will be returned. So, we are like very, very in a very precarious situation. We don't know who has received all of the vaccines. We're in the same place that we were around the testing data, where we don't have the sort of demographic and ethnic breakdown of the data. And this is really indicative of larger persistent issues in our public health infrastructure. And I think the federal government has an incredible opportunity to kind of dismantle some of these systems that have created some really significant barriers for local government, for state government, and for the federal government to not only lead through this pandemic, but to make sure that our most vulnerable populations across the United States are deeply connected to the resources that they need to navigate through the pandemic, to understand how it's impacting their families, and to get the care that they need so that we can heal and move forward.
Well, you mentioned vulnerable populations. Of course, that terminology is a part of a number of different terms that really relate to health equity, something that we all care about. And it occurs to me, certainly based on practice, that not everybody is collecting the data that will help us to analyze and get to health equity. Are you seeing the same things? Is it being collected, data on age and gender and race, ethnicity, and other factors that could really help us better understand?
Yeah, I mean, this is the crux of the issue. It's not being consistently collected. So we know that we are having persistent challenges in just even creating that common language. One of the things I admire most about the GIS community is that they spend a lot of time thinking about how do we define things in the same way? How do we create standards, and we create collection methodologies that can be scaled across geography? And that's not what we're seeing right now. We're seeing states taking different approaches on how they define things. We're seeing states taking different approaches on what data they are collecting. And while we have greatly improved our visibility into who has died and who has contracted the disease, we are still not getting any consistent data around who has access to testing and who's getting vaccinated. And so it's something that is really going to impair our ability to comprehensively respond to what is still a very much active pandemic here in the United States.
Well, I think it's a really big change in mindset that would have to occur in order for the federal government to really be a stronger force with the state and local governments to say this is mandatory and we need to do this. Of course, the states have traditionally done things their own ways, and we can see some of the ongoing issues with that, as you've mentioned. And it makes me think of something else that you were saying. You were talking about data and aligning with policy. So this mindset change is one part of that, but I think you also meant other things in terms of data aligning with policy and sort of that idea of actionable information. Do you want to elaborate on that a little bit?
Yeah, I mean, I think you of all people know that this has been the center of my career in government, outside of government, which is that, this database should be driving decision making. And honestly, up until the first vaccination started being disseminated in our communities in the last several weeks, months, public policy was our only lever. It was our only intervention that we had to stop the spread of the disease, to slow the spread of the disease. And when I talk about public policy, I'm talking about mask mandates, I'm talking about closures of schools and economies, and all of these decisions are being framed by data. And it's not just data around this disease, it's kind of those critical data sets that all governments are collecting around the populations that are being impacted, the census of how many children are in school, how many have access to the resources they need to learn at home. We have seen emerging data in the fabric of public health that we've never seen before. Things like broadband all of a sudden is a critical public health asset. Things like whether or not we have transportation so that you can go to drive-through testing or vaccination sites. These are questions that are answered by public data sets that far expand the kind of traditional epidemiological data sets that we're using to model disease. These are things that we know mayors and governors are using all the time to influence budget making and policy making. And I'm not sure we're quite there yet, really, at that sort of nexus of being able to speak in in that common language and really understand how we should be framing our use of data in decision making. But we have been tracking these policy decisions up against the disease, and you can really see the impact that some of that smart thinking has had on outcomes in disproportionate places across the array of response we've seen in the US.
Well, and that goes to the geographic question, which I'm passionate about. But you mentioned, you guys are working on that, and I know you're doing a lot of great things. Everybody knows about the dashboard that has been seen trillions of times now and used very effectively. And we talked about the data sharing, but you guys have been doing other cool things. Do you want to talk a little bit about what you're up to?
Yeah, so this is where we sort of are now, and we continue to evolve the resources. We have enjoyed a great partnership with Esri around the global map, and that is really something that we covet at the university, and have been able to share not only the sort of base of our tracking for the map and in our US views, our dashboards with local governments and states that have been replicating and using our data to power their own decision making. But we're looking forward now to figuring out how can we start to really use the full breadth of resources that are available to us to track things like our hospitalization rates and what are the intersections of our hospitalization rates against not only the ebbs and flows of the disease, but around the capacity that we just have in our health infrastructure. And so we're using tools now that we haven't been able to use up until now to really start looking at that data and to really visualize that data all through sort of the ARC GIS platform, but really understanding the intersection of the technology and the kind of problems that we're trying to solve has been a really exciting moment for us. And so you'll see some of that developing in our analysis. We're using a lot of public health expertise too. One of the benefits of being at Hopkins, our mission is knowledge for the world, and we're bringing in public health expertise on vaccination, on testing, but also on some of the real constraints that our communities are feeling as it relates to access to services. And we're trying to connect that deeply with the data. So we're going to see also some of that analysis emerge out of this and start thinking about how do we democratize science in a way that we've been able to in COVID to really get at some of the more deeply rooted issues that our communities are facing.
That's so cool. You guys are doing amazing work. And I do have to say, I especially love your hospital capacity map, to be able to watch the capacity change over time and get that temporal component. And then even just the decision making as a physician or as a public health leader, to be able to see, nearby hospitals where one has capacity and a number of others don't, and you can see the direction of infection spread. I mean, it's like, okay, well, the decisions then become obvious in a way that they never were before. So I appreciate the work that you guys are doing very much. As we think about, again, this audience that is watching us have this conversation, I think of them as the change makers, right? These are the people in our government who are actively working to make our country a better place and to solve the problems of the pandemic. So if you had your wish list and you could ask these folks, what would you say would be the most practical early steps with all of your years of data expertise that you wish we could all take moving forward?
I think that it's not the most exciting area to think about, but governance has been the real Achilles heel of our pandemic response. The fact that Johns Hopkins University is still powering a lot of the data and a lot of the view of the way that this pandemic has unfolded is really a call to action around how do we start to standardize the way that we think about data collection in a global pandemic, but also just generally in the field of health. And start creating some of that governance, whether that's with our international partners or whether that's here just in the United States, so that our states are not positioned to have to kind of navigate these really incredibly difficult circumstances without that kind of North Star, without that kind of ability to borrow good practice from their neighbors, to borrow good practice from the federal government. I know that there are lots of committed public sector workers that are actively also trying to create these economies of scale, and being able to have some structure, some ability to speak those common languages are going to go miles for our practitioners, who I know are deeply committed to deploying resources and solutions fast and at high quality.
Okay, well, I think that's a great answer. And I'm just going to disagree with one part of it. I think if we imagine the outcome, governance becomes very sexy. And so for all of the audience, you heard it here first, focus on governance as recommended by our expert today, Beth Blauer. And thank you. It's so good to catch up with you, Beth. And thank you for all the work that you and your team of women leaders in tech are doing at Johns Hopkins University.
Yes, thank you very much for having me. It's always great to be here with you.